Welcome everybody to our hip fracture registry lecture series. I'm Jacqui. I'm one of the co-chairs for the hip fracture registry. And with me today is Dr. Matthew Beech, and Matt is a specialist anaesthetist up in the Gold Coast. So a warm welcome to Matt. And he's going to be talking to us on that perennial thorny issue of the role of the echocardiogram in hip fracture care. So, Matt, what is the role of an echocardiogram in hip fracture, given the concerns we have with delaying surgery for an echo? So tell us what sorts of things you are looking for.
Yeah, look, I certainly appreciate there's an association with delays there. I guess what we're trying to do with our preoperative assessment in general is identify patients that aren't going to tolerate the perioperative period well. So certainly those at higher risk intraoperatively and early postoperatively. We know that femoral fractures have a significant mortality rate, and one of, if not the leading cause of mortality, is from cardiac events. So we're trying to identify high risk cardiac conditions, and the ones that we're looking at are dilated left ventricles, left or right ventricular failure, and pulmonary hypertension. But certainly if there's a patient who's presented with previously undiagnosed heart failure or with a recent deterioration in the signs or symptoms of heart failure, I'd be interested in imaging them if they hadn't had a recent echo. Managing patients with moderate to severe valvular disease is also more challenging for us. So we're trying to identify those patients as well. And we certainly know there's a significant amount of undiagnosed aortic stenosis in this group. So certainly if you've got somebody with a clinical history or signs that are suggestive of hemodynamic significant aortic stenosis in the presence of an ejection systolic murmur, they'd be a group that I'd be interested in getting imaged as well. But it's challenging to come up with an exhaustive list. And I think really to address that potential delay, you need a collaborative approach. There's a lot of different ways that issue can be addressed, but I think the solution you settle on is very much going to depend on the preferences, the skill set and the resources at each facility. Keeping in mind at the end of the day, it's an emergency procedure, so there really does need to be a pragmatic approach.
Right, thanks, Matt. And then what are you looking for on an echo? What information do you get?
Yeah, so look, for a formal diagnostic echo, there's a huge amount of information, but what we're really looking at are the big ticket items, so things that are going to make us reconsider our usual management. So we're screening for significant left ventricular systolic or diastolic dysfunction, significant RV systolic dysfunction or pulmonary hypertension, and moderate or severe valvular stenosis or regurgitation. And the other useful piece of information is the current filling status of the patient. So do they appear normal, normovolemic, relatively hypovolemic, or significantly vasodilated? Yeah.
And given that we can't actually change very much of what we find on an echo, what is it that you guys do differently as a result of being armed with that information?
Yeah, it's a really good question. And I think that the one prospective study showed that it does make a significant difference. So having those results with up to 1/3 of patients having their management changed when an anaesthetist was presented with an echo result. Preoperatively, it lets us have a more informed discussion with the treating teams, with the patient and with their next of kin. And in the case where the risk is significantly elevated, that may sometimes involve a change to the surgical plan. Intraoperatively, what we do exactly is going to depend on the pathology, but there's about 5 main things that we'd consider changing. We would look at whether or not a spinal or a general anaesthetic is more suited to their particular pathology, which is an issue for a debate in itself. Do they need more invasive monitoring? So critical aortic stenosis or significant pulmonary hypertension, it would prompt many of us to place an arterial line before we started with these cases. We would consider running, in some instances, vasopressors at the start of the case or before induction or before we place the spinal And in very rare cases, we may even consider inotropes if the pathology was severe enough. It lets us inform the intravenous fluid we administer. So some patients are going to be very intolerant to either hypo or hypervolemia. And some patients will need a bolus before we induce them, or again, before we place the spinal. And it informs our hemodynamic goals. So patients with significant diastolic dysfunction or valvular stenosis, we would aim to run at a lower heart rate, whereas in the case where there was significant regurgitation, we would look to push that heart rate up, and we'd certainly change our blood pressure targets based on the pathology we saw as well. And then finally, post-operatively, look, the majority of these patients are transitioning from having one-on-one care with a physician by the bedside and continuous monitoring to ward-based care with intermittent monitoring. And so if we can identify those patients that are at a higher risk, we can consider HDU admission, look at a lower nursing ratio, or plan a medical review at some stage during the evening to try and identify and manage deterioration as early as possible.
Great. Thanks, Matt. That's actually really useful on a number of different levels. So yes, there is a role for an echocardiogram. You've highlighted the types of patients that we probably should be doing an echo on and how your management changes as a result. But I think the other thing you emphasized was also that we shouldn't be delaying surgery. We should have we should be having pathways in place that allow us to expedite echocardiograms if we need them, so that surgery isn't delayed. And that's a very nice pragmatic approach to using echoes in the context of hip fracture surgery. So Matt, thank you very much for your time, and thank you everybody for your attention.
Thank you.